Hi. Mainly to Ebony, I was just wondering with the metronome if you have a particular rate that you're looking at for the metronome, and also is there a particular reason that you did auditory versus visual, tactile, or those sorts of things, or was it purely convenience?
That's a really good question. We certainly don't have all of the answers. So what we did was base it on 60 beats per second, because that was what had been done in the neuroscience kind of literature. And it was also important that it was a slightly longer eccentric component when you're doing the isotonic one. And I'd be really happy to show you. It's really easy. It's just a free metronome app. What was the other part of your question?
The other inputs.
Oh, yeah, okay. So we thought about the usability of it, and we thought if we did an audio one, they could use the headphones and we could just send it to their iPhone. So equally, they could have probably done visual, and we thought tactile might be a bit weird in a public space. They were young jumping men, so we thought.
What was the metronome frequency, sorry?
60 beats per second.
60 beats per second?
Per minute.
Sorry.
Oh my gosh. My brain's saying, where's the coffee? Yeah.
I've been doing it wrong. I thought, oh my God.
60 beats per minute, yeah. 1 beat per second.
Yeah,
Thank you.
that's very quick.
I might add something to that. I'm on Lewis here, am I? Well done. I really love that question as well. And from integrating that question maybe with Sarah's talk too, one thing we know about vision is that it's a really precise network, like it's our most precise sense. So my prediction would be that if you could wing it somehow, visual would be a really useful way to promote that cortical plasticity in a really precise fashion. But even better than that, there's really good evidence that if we can recruit two senses at the same time, we'll even have we call it super additive. So the effect of vision alone plus the effect of auditory alone will be smaller than the effect of vision and auditory together. So my prediction on that, and I'm sure yours is too, is that auditory wouldn't be the only way, but you need to engage the brain in the task in a way that the brain has a behavioural objective.
Yeah. And we're doing that study later this year.
Hi, anyone who'd like to answer this question. I get brain ultrasounds, and there might be 4 pathologies on the ultrasound, and 2 might be asymptomatic, and 1 is a neurological and 1's a more of a tendon issue. I know you didn't mention anything about a gating theory, and I often, you'll treat some presenting, like 2 feet have the 4 pathologies, and you treat 1 foot, and because that was the main presenting at the time, and then the other foot starts hurting once you fix it. I know you didn't mention anything about the gating theory. Your thoughts on that?
Just anybody.
You dived in. So are you referring to the gate control idea?
Yes.
Yeah. I guess the key aspect of that theory, so that was the 1965 Melzack and Wall, the most influential shift in our way of thinking, probably in the last, probably ever. And in short, this idea of giving competitive input at the spinal cord that's not nociceptive as a way to reduce the nociceptive input going up to the brain. The best data on that still say, yeah, that's feasible, but it targets one kind of spinal nociceptor, which is the nociceptor travelling from the dorsal horn to the thalamus. And it doesn't target the other one, and it's the other one that's the problem in chronic pain. So there's pretty good evidence now that anything we do that just targets that gating, as you call it, for chronic pain won't work. And the transient pain relief that we get, so often in the physio world, we'll get pain relief for 2 or 3 days from those techniques. And we now understand that that's because of brain-released proteins, really like morphine-type proteins, not because of a gating effect. I'm really interested also in that experience that you describe, where you treat one and then the other side starts to hurt, or even a new pain emerges. I find that really interesting, but probably more from the perspective of the organism prioritising protection, and I would interpret that as it just didn't satisfy the threshold for protection until it was the most important thing to protect. So I'd probably interpret it that way, and there's a lot of immune-based mechanisms that give you mirror stuff that maybe Dave Butler will touch on tomorrow, I'm not sure. But
Thank you.
My name's Nigel Rowe. This is a question for Lorimer. If I have a patient who's got, or I feel has just developed chronic regional pain syndrome, how would you, as a clinician, go about trying to explain that to a patient to obviously have the positive and not the negative connotations that could drive?
thanks, Nigel. That's a killer. I would definitely try to do that. I guess there's something in your question that triggered a different answer depending on the answer to that one. That was if they just started to develop CRPS. So I'm pretty convinced that if we truly get them in that first development stage, within a couple of months of the injury, which is where you guys might see them after ankle scopes or something like that, or forefoot sprains, I think they're a bit more common than ATF sprains or rear foot stuff, then I would explain it to them as all we understand about this is that the inflammatory and autonomic protective responses have gone berserk, and what we now think is that they're not getting switched off. For some reason, we don't know why that is, and it's mainly bad luck as far as we can tell, a bit of genetics. But what we do know is that if we can get that under control and convince your brain not to protect it, there's a really good chance of resolution. So if you get them in that first sort of 6 to 8 weeks, what I'd also do is get someone who can blast them with steroids to really turn off that inflammatory response, and possibly analgesics, but the only good data at the moment are on steroids. It's unpublished, but I know the RCTs have finished because I've been involved with them. If we're after that magic zone, somewhere around 2 to 4 months, CRPS flips into a central nervous system maintained disorder. And that's where your question becomes the killer question, because not literally, obviously, but it's a really challenging question. And I guess what I would want to get across to a person in that situation is that we think their problem is driven by central nervous system mechanisms, and we need to now retrain your brain to stop protecting this. It's not you that we're retraining, it's no fault of your own, no decision you made, but your system's responded in this way, and we need to now target the brain. So in some ways we would be treating you as though you've had a stroke. Now you haven't had a stroke. That's the good news, but that's the extent of training that we need to embark upon. And what we know absolutely is that if you stick at this little by little and you stick at the training paradigms, we know there's a really good likelihood of resolution. It won't be fast. There's no magic bullet, and that came up, I think, certainly in Ebony's talk, but in others as well. But it's a training paradigm now. And ultimately, the core objective of our training goal, of our training program, is to get your brain to use that body part, so I presume to use your foot normally. Whatever we have to do to get that to happen is the best chance we've got of turning this around. And we need to negotiate that, because it's going to hurt. If you just go and do it tomorrow, it'll be so painful, that probably freaks you out. So we might try a more gradual training approach. Having said that, this is not really a question, but having said that, there's a really interesting new RCT, and I know the group who's done this, where they've done pain exposure therapy for CRPS of the feet. And it's incredible to be in the room, but they basically convince patients to weight bear and jump onto their foot, and they're terrified. They're crying, and they're screaming, and they're shaking, and the clinician is there saying, do it, it's not going to damage it, just trust me on this, do it, you can do it, you can do it. And the patients who do it respond in a similar way to our RCTs, which are programs that take months. They, in this one trial, have got similar gains in weeks instead of months. Which is what encourages me to say we have to get the brain using this body part. That's the clincher. But to be able to convince the patient that it's not about the body part is the real challenging. It's the challenge that we have as a clinician. And we spent 20 years working out how to explain this stuff to patients. And we've got a big data set to say that of all the chronic pain groups we get, the ones who don't respond to the normal way of explaining are CRPS and migraine. So we're still working on the best way of CRPS, but it's a really verbose response to your question, but I hope it made some sense.
Can I just add one more?
Yeah.
Sympathectomies for those, really chronic cases seem to work short to medium term. Why don't they seem to work longer then, if you are getting them back to function during that period that it's working?
Yeah, great question. So the best data on sympathectomies are that they work in about 15% of CRPS cases, and our interpretation of that is that those 15% are not CRPS. They are sympathetically maintained pain, which is a different biology. And there, the pain, sympathetic nervous system pain vicious cycle that we used to categorise for all CRPS, when we called it RSD, reflex sympathetic dystrophy, we now interpret it as a disruption in the dorsal root ganglion, possibly the spinal cord, but probably the dorsal root ganglion, where there is this coupling of the autonomic and the somatosensory systems. The reason that 15% of them, and they're cured actually, as a rule, they're better. The reason that the other 85% might get a response, sometimes they get it for days, sometimes they get it for weeks, and sometimes they get it for 3 or 4 months, we interpret as a mechanism not mediated by removal of the sympathetic trunk or denervation of it, but it's mediated by all the other stuff that we've all alluded to, the powerful safety cues that come with that, which many would describe as placebo, and I don't, because we know more about it than just simply stuff we don't understand. Yeah.
Hello. I have a question for Sarah. I was wondering about your judgment on neural representation in the presence of amputation or a prosthetic limb.
Yes, so do you mean after sporting?
Not
I'm assuming not
necessarily.
after sporting. Yes, so I think there's, Laura might be able to correct me, but is there GMI in amputees yet? Or there is?
Yeah, so one trial we did included amputees, and they respond just like CRPS.
Yeah, so the GMI seemed to be effective for people with amputees, but obviously tactile training's a little bit more difficult in that cohort.
Sorry, can I add something to that? Sorry, I don't want to be the hijacker, but there's really exciting new directions in that field, looking at this idea of visual, trying to combine senses that came up earlier. So there's really interesting work at the moment where people are looking at tactile training where the visual input is coming from a realistic looking prosthesis, and we've known for a long time that prostheses are really important in limiting phantom limb pain, and a myoelectric prosthesis is the best one we can have to limit that. So the trials that are happening at the moment, the data of which are not back, but I think it's a great idea and the pilot data are really strong, is that they do tactile training where they get a tactile stimulus on the stump that coincides with the visual stimulus on the prosthesis. And it's almost like that rubber hand illusion in effect. And the pilot data on that are really cool. There are sensory discrimination training just on the data, just on the stump without a prosthesis, which Herta Floor published 20 years ago, I think, and was a good therapeutic response. I would predict this will be better. And it's a really innovative and excellent idea. And I reckon we'll know that in 2 years or something like that.
Thank you.
Do you have clinically a tool or something that you can give to the patient for them to perhaps take away and read or study so that they can start that process of getting their brains thinking the way they should? If it's such a complex thing as you describe, for them to grasp, obviously a key part in the treatment is going to be starting that training. How do you do that?
Yeah, that's great. And what I love about that question is the insight into making them fertile ground for this really possibly confronting message, which is a bit confronting to us as clinicians sometimes as well. I mean, as a physio, all of our training was about the body. So that's been a really interesting journey for me, and I know for many physios, and it's probably similar for you guys. We do have tools. So I'm one of 4 authors on a book called The Graded Motor Imagery Handbook, which has a lot of information about educating people about the situation and understanding the contributions to the conceptual barriers that people have. Now that's a book aimed at clinicians, or really, really switched on patients, but probably clinicians. If you buy that, I get royalties, so it's in my interest in telling you it's good. There was, I think Sarah had a picture of that. Yeah, it's called the Graded Motor Imagery Handbook. It's published by David, who speaks tomorrow, and he's a co-author, and he and I are great friends. He takes me to lunch once a month, breakfast actually. I take him to breakfast once a month as well. But we're not sleeping together or anything, but I've got lots of conflicts there. So aside from that, the treatment tools are well established. They're as an app called Recognise, and I think there's still a computer version, but I think it's all going to tablet and smartphone apps to do the graded motor imagery. But as far as bringing a patient around to that possibility, at the moment, I'm still convinced that we need a really clever, persuasive, empathic, disciplined clinician to help them on that journey, because it's inconceivable if you don't understand the true fearful and wonderful complexity of pain. It's inconceivable that the foot's not the problem. Because look at it, it's swollen and withered or twisted, or how can that not be the problem? Are you telling me? And so a big part of, like, when I assess someone with CRPS, I do all this stuff to their painful body part, and most clinicians are frightened to touch it. Right? I'll grab it and I'll move the joints, and they'll be doing all their stuff, and there's a lot of behavioural therapy going on. I don't reinforce their protective responses, but I reinforce their non-protective. And a lot of that is almost like, this is the show to commence the process of convincing you the problem's not there anymore. This is a problem of representations and hyper-protection. So the same old stuff that we would apply to anyone with chronic pain, which is the whole explained pain model, is, as I said before, is our data are just not that good that people with CRPS embrace that. And I think that might be because they're clearly different to everyone else with chronic pain, because they've got a mutant body part. It's just so bizarre looking and frightening, and I'm not like them. You know, I'm not like those people with back pain or whiplash or headache or fibromyalgia. Look at this. You telling me it's in my head? Have a look at that. So I guess my response to that question will be more a bit like Sarah's response to another question. Take on the challenge of upskilling to take on that role and recruit other like-minded clinicians that are not podiatrists in that circle of trust. So if you can get a medically trained person, a physio, all saying exactly the same thing, then I think you've got a pretty good chance. But until they get it, until they buy in, I reckon you're peeing into the wind a bit with that.
Have you looked at the psychology of the buy-in? Because you may be aware I do live with a PhD psychology. So she has a very different perspective. She went to your conference a few weeks ago and she was looking at her side of things. So what are the psychological aspects of a person who may buy in or not buy into that treatment?
Yeah, so, I mean, psychology is the clincher on this stuff. So we've done a lot of work looking at persuasion, conceptual change, and Dave may talk about the conceptual change stuff tomorrow, but there's a lot of data in fields that have names like conceptual change theory, cognitive architecture, persuasion, these sorts of things that we rely on a lot, and in the treatments that we've devised. When we say treatments, they're cognitive educational treatments. There's a lot of work on the stages of change stuff. I can't remember that conversation to which you refer, but I often get questions about what about their readiness to change? And I'm no expert on that, but I reckon there's good evidence that people will be more or less responsive in some sort of cycle, and even some days. There's a lot of stuff from the experimental psychology literature from the fella Kahneman, who won the Nobel Prize and wrote Thinking Fast, Thinking Slow. It's a great book. There's some really good tricks to to get people to agree with you. Salespeople do it all the time, but clinically we can do that, right? You put someone in the yes space and give them a new piece of information and they're more likely to have it stick. So there's a lot of that sort of stuff. And then there's that entire body of research that the clinical psychologists have been working with for a long time, really well, broadly covered by cognitive behavioural therapies, acceptance commitment therapy, mindfulness, all that sort of stuff, which is aimed at the behavioural end. And they're experts at that, and I'm not. And we're targeting more the mechanisms by which and the criteria according to which the brain protects your body, not how you respond to the pain. Yeah. Did I get it?
Yeah, thank you.
Cool.
I just wanted to respond to that because you're actually sort of killing me softly with your song, because you're actually telling my story without you probably realising it. So my name's Jane and I'm actually going to speak with Nigel Rowe after lunch just to talk about the patient experience. I just felt that I needed to respond to say that for me, what you've talked about has made an enormous difference. So as practitioners, I just plead with you to keep going with this information, keep working with your patients who may have symptoms of CRIPS, and stick with us, because we actually really, really need you to develop your knowledge of this to help us. And it does make a difference, and I've been very fortunate with the practitioners that I've had that have helped me do all of these things. I've actually worked through a lot of the graded motor imagery stuff with your programs and your Explain Pain book, Lorimer, so all of that has been enormously helpful. I don't get royalties for saying that. But I just felt...
For some?
Sorry?
Are you angling for some royalties?
I'm actually meeting with you next week, so that's, high on my list of questions now.
Cool.
The others have paled into significance. But look, I needed to say thank you to all of you for talking this morning. Knowledge is power. I'm a teacher, so I'm all about learning. But a lot of what you've said this morning has been new to me, but it's added to my knowledge base. So again, stick with us, keep talking with your patients and giving us the knowledge. And as always, that means that you might need to learn something yourself. So thank you for all of your work.
Fantastic. Thanks for that. That was lovely.